Хорошо. Всем здравствуйте, коллеги.
Hello, everyone.
Всех очень рады видеть.
Very happy to see all of you. Thank you very much for
Это
being here
одновременно
at
и
our open talk.
лекция,
It's at
которая
the same
будет
time
одновременно
an open
первая
talk
лекция в нашей программе «Гендер,
and
сексуальность и
the first
этический
talk at our
психоанализ».
program on gender in
В программе будет 27
psychoanalysis.
занятий.
This program
Вот.
will consist of 27
Я представлю
classes in total.
доктора Марка Блэшнера, он доктор
I'm very
философии,
happy
тренинг
to
психоаналитических Вильяма
introduce
Алансона Уайта,
our today's
клинический
speaker,
супервизор и один
Dr.
профессор
Mark
постдокторской
Blackner,
программы по
PhD,
психотерапии и
a training
психоанализу
analyst
Нью-Йоркского
at the William
университета.
Alanson White Institute, and a clinical
Он
supervisor
автор
and adjunct professor
4
at the
книг,
postdoctoral program in psychotherapy and psychoanalysis at
он
New
был
York
также
University.
основателем и директором
He
клинической
has published 4
службы
books.
по ВИЧ-инфекции в Институте Уайта,
He was the founder and
является
director
почетным
of the
редактором
HIV
журнала
clinical service
«Современный
at the White
психоанализ».
Institute. He is the
И в Институте Уайта, в
editor of the
котором он
journal
является
Contemporary
научным преподавателем,
Psychoanalysis.
он также учредил
And
стипендии
he has
для
also
финансирования
established
обучения
fellowships to fund the
этих коллег.
training of candidates of color
Также автор многочисленных
at the William Alanson
статей.
White Institute.
Очень рады вас снова видеть.
Very happy to see you again, Dr. Blackner. It's a great honor. Thank you very much for making it, for being here. And the floor is all yours. We already have almost 500 participants.
Oh my gosh. Okay, well, thank you. Thank you for that very gracious introduction. And I thank you to Nikolai Petritsa for inviting me to speak to you today. I'm going to make one adjustment to what he said during the introduction, which is that the scholarship that I have funded is not only for people of color, but also for transgender psychoanalysts. And that's actually something I'm going to speak about a little bit later on. I also want to thank in advance the translators, because this talk is going to have some very difficult things to translate. It has a lot of words in it, some of which even my American colleagues asked me, what does that mean? So I've tried, I will try to explain what some of the terms are as I go along. And if anything isn't clear, maybe during the discussion period, you can ask me as well. So thank you all for being here. I'm going to talk about psychoanalytic counter-resistance to sexual issues from 1980 to the present day. So right away, there's a word counter-resistance that I'm not sure you're all familiar with. Freud talked about the resistance of the patient in psychoanalysis as a very important factor, but there is also the resistance of the psychoanalyst, and we call that counter-resistance in English. Counter-resistance is the psychoanalyst's resistance to hearing, knowing about, or connecting with material brought up by the patient. And in this lecture, I will explore specifically psychoanalyst counter-resistance to sexual issues, as shown in several ways. 1, barriers to hearing what a patient is talking about and engaging with sexual material. 2, ignoring the patient's stated aims for the psychotherapeutic treatment. 3, gaps in the psychoanalyst's objective knowledge. 4, narrowing of the psychoanalyst's perspective because of social and cultural factors. And 5, when psychoanalytic institutes and journals block lectures or publications on issues of sex and gender identity that provoke anxiety. I'm going to start with a personal experience that launched my interest in this topic. When I was in my first year of psychoanalytic training, I was assigned the case of a man who was involved in dangerous, violent, masochistic activities. My supervisor, after hearing about the case for 3 sessions, said to me, "I can't listen to this. It makes me too upset. I don't want to hear about it." I was startled when she said that. I thought, perhaps I was naive at the age of 29, but I thought then that a clinician had an ethical responsibility to try to help whoever came for treatment. So I continued to work with the patient, and I did the best I could on my own, since I stopped discussing the case in supervision. It was my first experience of a senior clinician's counter-resistance to sexual issues, but not the last. I have heard from many patients who were faced with an analyst who didn't want to hear about the sexual issues that were troubling them. For example, a man who was a heterosexual voyeur would be asked by his analyst, "Were you disgusting last night?" She didn't want to hear about how he enjoyed watching women through his telescope against their will. In another case,
I'm sorry. Вы могли бы, пожалуйста, говорить немножко помедленнее?
Sorry, Mark, to interrupt you. Could you please slow down a little for the interpreters to be able to
okay.
process?
I will
Thank
try.
you. Sorry for the interruption.
Tell me again if I'm too fast. Okay. In another case, a gay man who dropped out of college because of severe anxiety about his attraction to other men was sent for consultation to a psychoanalyst, and that psychoanalyst said to him, "But doing things with girls is fun." The patient, who was already withdrawn, completely clammed up, became completely quiet, and ended up being hospitalized, having 2 weeks of electroshock treatment. These are some of the different ways that we can see counter-resistance to sexual issues. You can read about more of them in Shalev and Yerushalmi's landmark paper from 2009 with the title, "Status of Sexuality in Contemporary Psychoanalytic Psychotherapy as Reported by Therapists." The analyst can become judgmental. The analyst can try to ignore what the patient is saying, or change the subject, or say something so out of touch that it is a conversation stopper. The analyst can avoid any inquiry at all. Counter-resistance also appears in psychoanalytic institutions, as when journals decide which articles cannot be published, or institute cancel speakers with viewpoints that offend them. Is that slow enough? Can you, interpreters? Freud put sexuality center stage in the psychoanalytic scheme of motivation and at the core of psychopathology. He was in contact with the work of leading sexologists of his time. Yet paradoxically, most psychoanalysts today are relatively out of touch with sexual science and research. How many psychoanalysts regularly subscribe to journals of sexology? How many psychoanalysts give talks at sexology conferences? And how many psychoanalytic conferences invite sexologists as speakers? One of the effects of my being known as an openly gay psychoanalyst was that I received many referrals of people with unusual sexual predilections, such as practitioners of ritualized sadomasochism, or a man who liked to urinate in his pants by being hugged by his lover, and many others. I was puzzled at first why I was receiving these referrals, because I knew almost nothing about these sexual practices. The referring doctors may have presumed that I, being gay, knew a lot about seemingly unusual forms of sexuality. This was wrong at first, but eventually it became true as I struggled to find my way with these patients. In time, I evolved a way of informing myself about their sexual desires experimenting with the theories that I read about, and ultimately forming a kind of general strategy for treatment, which I'm going to outline for you now. One issue is simply acquiring knowledge. When the AIDS epidemic started, Abraham Verghese, who was a heterosexual physician working in rural America, realized how little he knew about homosexuality, and he coined the term homo ignorance. It was an important word, different from the word homophobia. Homo ignorance was defined as a simple lack of knowledge about homosexuality, and it is different from homophobia, which implies hatred, fear, and bigotry. Homo ignorance was once common among psychoanalysts who had learned little about gay men and lesbians during their training, and much of what they had learned was false. But today, it's not just homo ignorance that is a problem. I think there's a lack of knowledge among contemporary psychoanalysts about many varieties of sexual and gender expression. Besides homo ignorance, there is also transgender ignorance. Transvestite ignorance, intersex ignorance, voyeur ignorance, and much more. Think about it. What were you taught during your psychoanalytic training in courses or supervision about the following: transgendered individuals, exhibitionists, and stone dykes? Stone dykes is a hard word. Stone dykes are lesbians who only want to stimulate their partners sexually. They do not let their partners touch them sexually. I will be interested to hear during the discussion, actually, if you have gotten in your training anything about these issues. I was taught little or nothing about these in my training. And what I was taught was often haphazard, anecdotal, and not very well informed. At the end of my training, I realized that I needed to educate myself about these things. As a gay man, I had often been displeased with the ignorance of heterosexual analysts about the basics of homosexual experience. I realized that I could be faulted myself for not understanding other sexual minorities. So I have come to formulate a basic principle. When I am referred a person who has a sexual predilection about which I have little or no knowledge, I go out of my way to educate myself about that predilection as thoroughly and as soon as possible. If the case is one that I'm supervising, I do the same, and I recommend that my supervisee do so too. Now, in the past, that required a trip to the library to do a literature search. But today, we live in the golden age of sex research, thanks to the internet. Almost every possible sexual desire or practice has a website devoted to it. You can also find discussions of virtually every sexual issue on Reddit or one of the other online discussion sites. People speak more openly and freely on the internet about the most personal matters, sexual and otherwise, with the protection of anonymity and the hope of finding people with similar desires. They also discuss their experiences with different sorts of psychotherapy, which were helpful or useless or actually harmful. Am I going slow enough, interpreters? Okay, I hope so. Besides the psychoanalysts having enough factual information, there's also the question of the psychoanalyst's basic approach when beginning treatment of a person with atypical sexual proclivities. How much does the psychoanalyst ask and pay serious attention to the patient's stated aims and wishes. How straightforward is the analyst about whether he is willing and able to work toward the patient's stated goals? How clearly have psychoanalysts determined what is possible and desirable clinically in such cases? And what are the data about outcome? And how aware is the psychoanalyst of the question of psychopathology versus cultural pathology? By that I mean whether the unusual sexuality is intrinsically problematic for the person, or is it problematic because society condemns that sexuality? And finally, how do the analyst's own life experiences and biases shape his or her clinical work? Our perception of other people's sexuality is shaped by our own sexual experiences, as well as what we have learned we should think and feel. Judgments about sex are very subjective. It's said that a promiscuous person is someone who is having sex with more people than I am. The pervert is someone who does things that I would never do. The person who is inhibited and constricted about sex is someone who never does what I would easily do. And the undersexed person wants to have sex less often than I would. The oversexed person is someone who wants to have sex more often than I do. So our judgments about sexual experience and behavior can be very subjective. Consider what you think about male cross-dressers. Despite the popular image, at least in the United States, of the gay drag queen who dresses up as Barbra Streisand, the fact is that the majority of men who want to dress up as women are not gay. Most are heterosexual, and the desire to cross-dress is much more common than usually thought. I became aware of what people know and don't know about cross-dressing when the journal Studies in Gender and Sexuality asked me to discuss a paper by Irwin Hirsch. Now, I have the highest respect for Irwin. His clinical accounts are always clear and frank, and more than with most clinicians, you feel like you know what really happened in the treatment. Also, like Freud, Irwin reports his failures, and I admire him for that. We learn as much from failed treatments as from successful ones, maybe more. In his paper, Irwin reported a case in which he treated a man whom he calls Z. Z has a great girlfriend and an extensive heterosexual history, and he likes to dress in women's clothes. Irwin tried to influence him away from cross-dressing, even though the patient never expressed a wish to stop the practice. Irwin thought that he could undo what he thought of as the patient's, quote, unconscious, archaic, girly boy identification with his mother. The patient quit therapy, and Irwin realized that the patient had never challenged him for what he called my egregiously unwarranted imposition on elements of a life he desired. How many of you have worked with a heterosexual cross-dresser in treatment? How many of your patients have stopped their cross-dressing? I ask this because if you look at the websites for heterosexual cross-dressers, I think you find that no cross-dresser reports getting rid of his desire through psychotherapy. Nor have I been able to find any such reports in the psychoanalytic literature. Instead, the consensus about therapy with heterosexual cross-dressing seems to be quite similar to therapies that claim to change homosexuals to heterosexuals. They waste a lot of money, put the patient through hell, and they don't work in the long run. For many heterosexual cross-dressers, what they most want is not to lose their desire to cross-dress. Instead, what he wants is to be able to dress up in his wife or girlfriend's clothes and then make love to her. This was the case with Irwin's patient, Z. Like Irwin, many psychoanalysts have a basic approach to working with people with sexual predilections that don't conform to the analyst's notion of normalcy. Their approach is to seek out the roots of the sexual predilection in the early relationship with the parents, with the aim of understanding the sexuality and perhaps changing it. Psychoanalysts are expert at coming up with plausible accounts of anything based on early parental relations, and at that we rarely fail. But unfortunately, these accounts too often make little difference in the patient's sexual pattern and experience. This approach is what I call the basic psychoanalytic premise. If we can understand the role of a symptom in someone's life, as well as its function in the patient's history, we can thereby help the person to get over the symptom. When applied to sexual behavior, the basic psychoanalytic premise is often applied. Exploring the developmental history of the patient will clarify the psychodynamics that cause the sexual pattern, and such analysis will lead the patient to understand his or her sexuality and no longer need the familiar pathological sexuality, so-called pathological sexuality, or failing that, at least to be able to foster a so-called normal sexual life in addition to the patient's non-normative sexuality. Although this sounds plausible, it is often false. Because there's so little outcome research in psychoanalysis, practitioners continue to proceed as if this approach will work more often than it does. The fact is that some non-normative sexual patterns have almost never disappeared because of psychotherapy, and it may be unethical to hold out the hope for such change to someone who may ask for it. Psychoanalysts need to recognize the unconscious significance of their attempts to steer a patient away from a sexuality that may seem repugnant to the psychoanalyst, but not the patient. As Joyce McDougall has written, quote, "The analysans themselves rarely wish to lose their erotic solutions. A number of patients, under the impact of the analytic adventure, frequently develop richer sexual and love relations. But should this not occur, then to lose the only system of sexual survival that they have been able to devise would be the equivalent of castration." In 2009, after I published my book, Sex Changes, Transformation in Society and Psychoanalysis, one of my former students contacted me. He said that he realized in reading my book that he had had almost no education in working with sexual issues during his psychoanalytic training. And so he asked me to lead a private seminar on the subject, and I agreed with a class of about 8 people. My original plan was to teach a 10-week course, but the students asked to continue, and we continued meeting every week for 3 years. We became a kind of independent research group on psychotherapy and sexual issues. The subject of sexuality is vast, and we studied many topics. The psychological factors in sexual excitement, non-traditional patterns of sexual expression, including zoophilia, which is having sex with animals, urolagnia, which is the pleasure in seeing or hearing urination, gerontophilia, which is attraction to older people, ephebophilia, which is attraction to teenagers, pedophilia, which is the attraction to children, prostitute usage, homosexuality in men and women, heterosexuality, bisexuality, and bigenderism, and asexuality. Masturbation, sexual fantasy, intersexuality, gender identity and transgenderism, the involvement of penis, vagina, anus, mouth, breasts, and other body parts in sexual practices, the anatomy of the clitoris, which I'm going to talk about more later, kinds of sexual excitement and orgasm in men and women, couples therapy with both opposite sex and same-sex couples, sexual dysfunctions, including inhibited sexual desire, impotence, which is men who have difficulty with erection, anorgasmia, which is an inability to reach orgasm, premature ejaculation, delayed ejaculation, and dyspareunia, which is pain during intercourse, fidelity and infidelity, monogamy and non-monogamy. We studied sex therapy techniques to treat sexual problems and how to integrate sex therapy and psychodynamic psychotherapy, especially in the work of Helen Singer Kaplan, David Schnarch, Esther Perel, and others. And we also read Robert Sternberg's wonderful theory of 3 different kinds of love. We reconsidered questionable psychoanalytic formulations about sex, sexuality, and gender identity, including penis envy, mature genitality, and perversion. We learned astonishing new things and many old ones. When we were discussing transgenderism, for example, one student said, "But transgender people were discussed in the Jewish Talmud. They were called the tumtum, and there were laws to protect them and other gender atypical people from harm." Despite the insistence of the current United States government that there are only 2 genders, Talmudic scholars describe 8 gender patterns. As Charcot said, "Theory is good, but it doesn't prevent things from existing." We read many first-person accounts of people with unusual presentations of sex and gender, and of their experiences, good and bad, in clinical treatment. For example, we read the autobiography of Renee Richards, who is well known in the United States as a transgender ophthalmologist and professional tennis player, who, while still a man named Richard Raskin, was in a classical analysis with Dr. Robert Bach, who was at the time the director of the New York Psychoanalytic Institute. We also read Dr. Bach's 1968 article describing the same case in the psychoanalytic study of the child. Bach interpreted to Richard that his wishes to become a woman were an illusion. He said that Richard's attempts to hide and mutilate his genitals covered up a wish to keep his genitals intact. After the self-abuse, he said, Richard was unconsciously relieved that his penis was still there and he had not been castrated. Richard considered the interpretation to be clever, but it made no difference in his wish to become a woman. He had sex reassignment surgery after ending the psychoanalysis with Dr. Bach. The Richards case shows that a psychoanalyst can make interpretations that are plausible, even clever, but not necessarily true. And even if they were true, they do not necessarily have any impact on the patient's experiences or wishes. By the end of the analysis, Dr. Back's counter-resistance exploded. He started yelling at Richard and issuing ultimatums and warnings, such as that if he went through with a sex change operation, he would become psychotic, which did not happen. In each class, we also had one clinical case presentation. We considered each case according to understanding the patient's clinical aims, the analyst's attitudes, the relevant literature, and the transference and countertransference. It allowed us to study firsthand trends in how we contemporary psychoanalysts approach sexual issues. In this way, our findings are a supplement to the data of Shalev and Yerushalmi. Our sample, however, was a group of clinicians who specifically were looking for supplementary training about sexual issues. So they were especially open to questioning their common sense presumptions. They learned not to presume that their individual negative reactions of confusion, anxiety, or disgust were necessarily reflective of the patient's intentions. Sometimes we brought in professional sex workers. We devoted an entire class to a meeting with a dominatrix and another with a prostitute, who I would say was a master of cohort self-psychology, although she never read a word of cohort. These meetings enriched our understanding of sexual motivations and their intersection with personality issues. The members of the seminar were all highly experienced and talented clinicians. Two of them were over 75 years old and had more than 50 years of experience doing clinical psychotherapy. I admit this is not a random sample and not a balanced way of collecting objective data. Nevertheless, it allowed us to make in-depth observations that might not have been possible with other methods, and that may show some significant trends, especially concerning objective knowledge, countertransference, and counter-resistance. The first fact is something I've already discussed, that all the students had little or no formal training in working with sexual issues in their graduate or postgraduate education. Many did not know the meaning of many practices and syndromes and had not been trained in how to address such issues when they come up in psychotherapy. So there was a question about lack of knowledge, but there also was the question of their personal comfort or discomfort with different sexual issues. Most of the participants in the seminar felt they were comfortable talking about sexual issues with their patients. But they changed their minds as the course progressed, and we focused on their countertransference. We observed certain trends in their work when they felt anxiety. One trend was a tendency to rush to interpretation. If the clinician feels uncomfortable with the specifics of a sexual practice, or if the clinician is anxious about not understanding it, a common defense is to formulate an interpretation of the interpersonal dynamics and developmental experiences related to the sexual practice. Unfortunately, the rush to interpretation can get in the way of the therapist really finding out what the patient is talking about. A second common sign of counter-resistance towards sexual issues is when the clinician avoids inquiring into the details of the patient's experience. For example, one of the psychoanalysts in the group worked with a 20-year-old man who told her that his repetitive masturbation fantasy was of raping a woman. I asked her how that fantasy went, and she responded, "I don't know, the usual." She assumed that it was what she considered a typical rape, in which a man forcibly inserts his penis into her vagina, and she did not want to know more. Nevertheless, she went back to her patient and inquired. This therapist then discovered that the patient's fantasy involved a woman in an elaborate balloon-like dress that made genital penetration impossible, so that the fantasy involved attempts at overpowering the woman, but without genital penetration. In another case, an analyst who was a heterosexual married woman presented her work with a single gay man, with whom she had already worked for 10 years. In one session, the man told her that he had met someone new, and together, in his words, "We did all my favorite sexual things." So I asked her, what are his favorite sexual things? She replied, "I don't know. Do you think I should ask him?" "Why not?" I asked. "Well," she replied, "it seems to me that that might be prurient." Prurient is a word in English that means excessive interest in the sexual experiences of another person. So I said to her, if a married heterosexual woman told you that she did all her favorite things, would you consider it prurient to ask what those things were? She said, "No, that would be interesting." So I suggested to her that what she called prurient interest might be a byproduct of her discomfort with hearing from the gay man what his favorite things were, plus a fear that she would not be able to understand what he was saying and integrate it into her total sense of him. While with the heterosexual woman, she would feel less anxiety and more likelihood that she could identify with and understand her sexual proclivities. Now, the topic of sexual counterresistance is so large, and my time is limited, so I'm going to jump around a bit. I'm going now to speak about counterresistance to sexual issues in psychoanalytic history. It's my thesis that psychoanalysts from the very beginning have resisted hearing about particular issues of sexuality from their patients. We all know that Freud emphasized the importance of sexuality in human psychology, but Freud and his colleagues had certain blind spots to sexual knowledge. They were also limited by cultural biases of the time. And of course, the same could be said of psychoanalysts today. Since we have 145 years of psychoanalytic history, I'm only going to have to be selective. But let's start with the first case of psychoanalytic treatment. Anna O's treatment in 1880 for hysterical symptoms, including a persistent cough, hallucinations, rigidity of her limbs, neuralgia, absence of consciousness, and inability to speak German, only speaking English, and a cross-eyed squint. Dr. Joseph Breuer, a prominent physician and also a friend of the family, was summoned. Breuer met with Anna O every day for a year and a half and published the case history in the book Studies in Hysteria, which he published with Freud. It was the first psychoanalytic treatment, and it was, in my view, also the first case of counter-resistance to sexual issues. Now, some of you may know that Anna O's real name was Bertha Pappenheim. After Breuer's treatment, which he said cured her, she actually wasn't cured. She was in and out of psychiatric hospitals for 8 years, until near the age of 30, she moved from Vienna to Frankfurt, Germany. There, her symptoms suddenly disappeared, and she became a leading feminist and innovator in the field of social work. She started and led a home for Orthodox Jewish unwed mothers and enlisted many women in the Frankfurt Jewish community to help her. One of them was my great aunt, Irene Darmstädter, and so I have inherited many of Pappenheim's books and other primary documents, which I'm going to tell you about. Although many volumes have been written about the case of Anna O., almost none of them refer to the actual writings of Bertha Pappenheim. She published a book called Sisyphus Arbeit, which means Sisyphus work. She called it Sisyphus work because it was about her enormous attempts to eliminate forced prostitution of women, and which she felt she kept exerting herself, but then any progress she made fell backwards. And that book consists of letters written during her travels to the Middle East, where she was studying the forced prostitution of women and trafficking of women. The book is an enormously valuable resource if you want to know firsthand about Bertha Pappenheim's psychology. By the way, I'll just mention I am almost finished with translating the entire book into English, and hopefully we'll publish it this year or next. Yet most of the voluminous psychoanalytic literature about Bertha Pappenheim makes no mention of this primary source, and instead relies on Breuer's clinical report and speculation. So let me get right to the point. If you read Sisyphus' work, I think you will conclude that Bertha Pappenheim was a lesbian. She expresses a strong sexual attraction to women and a repulsion to men. She tells us a dream that suggests that she thought men smell like jackals, and that she resisted her mother's attempts to host potential men for her to marry. I'll read you one passage from Sisyphus' work that I've translated into English, and you can draw your own conclusions. On March 1st, 1911, Bertha Pappenheim wrote in Sisyphus' work, "The Jewish women of Saloniki are especially beautiful. The most beautiful one I saw here, maybe one of the most beautiful Jewish women I ever saw, perhaps the most beautiful alive, I found today in a brothel. What a pity, such a proud human flower, born in such an environment, to such a fate. I understand that a man will risk all for such a woman. Yet I can't understand this 20-year-old who thus sells the best, the most beautiful she owns, her body, in this way. Does she not have a soul? It's true she cannot write, cannot read. It's 10 o'clock. I'll stop my report for today to go to bed. Maybe I will dream of the beautiful Yolanta, who I cannot get out of my head since I saw her today." The text stands out for its eroticism. It's especially noteworthy because I have not found any passages in which Pappenheim expresses erotic attraction towards men. There's another fact of Pappenheim's life that is important. On many of her projects, she worked with a woman 38 years younger, Hanna Karminski. Hanna is referred to as Pappenheim's best friend and most intimate colleague. She was there when Pappenheim died in 1936. And Pappenheim once said with great pride, "Hanna is the young woman I have sculpted." And Hanna was a lesbian. Her life partner was a woman named Paula Furst, who brought Montessori education to Germany. In 1940, Hanna and Paula were still in Germany, helping the Jewish children of unwed mothers escape to England on the kinder transports. Their friend said, "Stay in England, don't go back to Germany." but they felt it was their duty to keep taking care of the children still in Germany. Hannah and Paula lived together in Germany until they were deported east and killed in 1943. By the way, there are streets in Berlin today that are named after Hannah Kaminski and Paula Fürst. When Anna O. began treatment with Breuer, she was a wealthy teenager in Austria from a distinguished family. She was expected to meet and marry a suitable young man, but we have no record of her having any interest in that. She never expressed sexual interest or attraction to any man, and in her later adulthood, she became an expert at fending off the seductive attempts of men. She tells us in Sisyphus' work that at the age of 50, on a boat to the Middle East, a man proposed to her that they get off the boat in Beirut and spend a week together. He told her, "I could show you much depravity." She was not interested. I think this connects with two aspects of Breuer's case report about Anna O. in the Studies in Hysteria. Breuer wrote, "The element of sexuality was astonishingly undeveloped in her. The patient whose life became known to me to an extent to which one person's life is seldom known to another had never been in love. And in all the enormous number of hallucinations which occurred during her illness, that element of mental life never emerged." Breuer was probably right that Bertha had never been in love with a man, but does that mean she felt no eroticism? If she was attracted to women, she probably knew that was unacceptable in her society, and she had better keep it to herself. We know that even today, many parents wonder, why is my teenager not dating? The answer is that many gay and lesbian teenagers are wanting to date members of their own sex, but they keep that secret. Bertha may have been one of those teenagers. The pressure on her to marry may have led to so much stress that she genuinely developed her psychosomatic symptoms. Or she may have fabricated her illness to keep herself relatively safe from being forced into marriage with a man. I don't know if Breuer had any inkling that Bertha's lack of apparent sexuality might mask her lesbianism. Nor do I know if Bertha ever tried to tell him and he dismissed it or blocked it out. But we do know that at the end of Breuer's case report in Studies in Hysteria, he tells us that Anna O said, quote, "She had not been ill at all, and the whole business had been simulated." Breuer wrote that this was a childish delusion, but what if it was true? I wish Breuer had taken her seriously and asked her why she made it up. Would she have known the answer? Would she have told him? Would he have believed her? Psychoanalytic understanding has often been limited by societal expectations and taboos that prevent the clinician from seeing the obvious and integrating it into the treatment. And now I would like to speak about another area of counter-resistance in psychoanalysis in relation to the clitoris. As many of you know, Freud distinguished between clitoral and vaginal orgasms. He proposed that vaginal orgasms were a developmental milestone to be achieved by mature women. The trouble was, Freud, like many people then, and even today, was probably misinformed about the anatomy of the clitoris. The clitoris is not, as many people think, just a little button of flesh at the top of the vulva. In 2005, Helen O'Connell a genitourinary surgeon in Australia, looked at anatomical scans and published a paper in which she showed that the clitoris extends internally through several stems, the crura, and surrounds the exterior of the vagina. So, as O'Connell told us in 2005, vaginal stimulation is clitoral stimulation. And O'Connell also tells us of the fact that 160 years earlier, in 1844, Georg Kobelt, a German anatomist, studied clitoral anatomy and described the structure virtually the same as O'Connell, with drawings that were remarkably similar to the recent scans, although not as vivid. And by the way, you can get a reprint of the Kobelt book on the internet today. It's in German, but the pictures are quite clear. Yet Freud did not seem to know about Kobelt's work, or he did not refer to it. I've not been able to find any reference to it in Freud's work. And the clitoris itself has appeared and disappeared in several alternating editions of Gray's Anatomy. In my paper from 2017, which had the title The Clitoris, Anatomical and Psychological Issues, I analyzed the possible psychological factors that make the true anatomy of the clitoris a fact that keeps disappearing from common knowledge and then requiring rediscovery. Counter-resistance to sexual issues is not just among psychoanalysts. Anatomists, mostly male, are resisting the knowledge of a sexual issue, the true anatomy of the clitoris. And now I'm going to switch topic again and talk about the exclusion of speakers from conferences. A further sign of counter-resistance can be seen when there are conferences about aspects of sexuality and gender identity without speakers who know about these issues from their firsthand experience. In the 1980s, there were psychoanalytic conferences on homosexuality in which none of the speakers were gay. It allowed for many misconceptions to be propagated. Psychoanalytic understanding of homosexuality did not really improve until openly gay psychoanalysts were brought into the conversation. The same is true today about transgender, in which when there are conferences about transgender, none of the speakers is transgender. Now, part of the problem is that there are very few transgender psychoanalysts, which is one of the reasons I set up the scholarship to train transgender clinicians in psychoanalysis. 2 decades ago, the East End Gay Organization in Long Island sponsored a panel discussion in Southampton, New York. It was way ahead of its time. There were 3 married couples in which the husband had transitioned from male to female. They and their wives spoke about the experience of transitioning and how they sustained their marriage in the new situation. One of the wives poignantly observed about her husband, who was now her wife, "I never had in mind that I wanted to marry a woman, but this is the person I fell in love with, and this is still the person that I love." This goes along with the principle I stated earlier, that if you really want to understand another person's experience of sex or gender, you need to hear from the person themselves. They can be more expert than the experts. A psychoanalyst needs to understand another person's sexuality and gender identity on its own terms. Sexuality is a core part of human experience, and sexual difficulties can be a large part of the issues for which people seek psychotherapy. In order to help patients, the psychoanalyst must learn the facts of human sexuality, an area of knowledge that needs constant refresher courses. No one person can know from his or her own small island of personal experience the huge continents of possible sexual life. Harry Stack Sullivan said that we are all more simply human than otherwise. But the ways we are different from each other, especially regarding sexuality, are important. We must learn from our patients what they want to achieve in treatment, and to be open with them about whether we can and are willing to help them achieve it. To that end, we must attend to our counter-resistance to sexual issues when we notice it or when our patients try to tell us about it. Our aim is to support our patients in finding sexual satisfaction and loving intimacy in the best way possible for them. Thank you.
Спасибо большое, Марк, за
Thank you
лекцию.
very much for this lecture.
Я думаю, мы сейчас можем сделать перерыв.
I think we can take a break now.
Постепенно
Okay.
появляются вопросы в чате.
There are questions sent in the chat, and then after the break, I will read some of them out loud to you. I think we'll have time to discuss quite a lot.
Хорошо, тогда.
How long is the break? Is it?
Вот хотел вас спросить.
So it's my question to you, how long do you want the break to be?
5-10 минут.
5-10 minutes?
5 minutes is fine for me. Okay.
Окей.
Okay.
5 минут.
10 is okay too.
5 minutes.
Читаю некоторые вопросы из чата.
Lots of questions in the chats. Read some of those. Just a second, I'll make sure that the interpretation is on already.
Да, да, хорошо. Хотелось бы, так, вопрос от Татьяны Мачуриной.
So the first question is from Tatiana.
Техники работы с парами, в которых один
Dr. Blackner, how do you work with couples if one of the partners has particular sexual predilections and the other has more conservative views on sexuality?
Well, that's a very big question. I'll just go back first to the example I gave of the man who was a cross-dresser. And it's a very important thing when people who are cross-dressers come as a couple with their wives or girlfriend. It's a general fact that if the man tells the woman that he's a cross-dresser early in the relationship, it's probably will work out better in the long run, although he runs the risk of her leaving him. But if, for example, he hasn't told her, she may feel betrayed and lied to, and that becomes an extra issue. And I would say that may be true with most couples where one of the people has something going on in his or her sexuality that they're not telling the other person. So I feel like you have to deal with two questions. You have to, or more than two questions. One of them is just what is the truth? And how does each person feel about it? Sometimes, people are okay with something that their partner tells them, and the partner kept it secret for so long and didn't realize that the other person was okay with it. I'll give you another example from the history of I don't know if Havelock Ellis was a very famous sexologist at the beginning of the 1900s. And actually, he and Freud interacted very much. And it turns out if you read Havelock Ellis's biography, he was someone who had what I described earlier, urolagnia. He got sexually excited by hearing or seeing his wife urinating. But he was married to a woman who thought it was disgusting. And so they basically had no sexual life for many years. And then when she died, he met a French woman who said, "Oh, that's okay." She thought it was kind of charming, and it was sort of fascinating to her that just by urinating, she could excite him sexually. And so they had a very good sexual relationship. So that's kind of there are issues that go on about how people feel about the practices, and then the secondary effects of secrecy and other emotions that are also part of a couple dynamic.
Спасибо. Так, еще один
Thank you very
вопрос.
much. Let's
От
take.
Марины. Фамилии нет. Хотелось бы также коснуться темы порнозависимости в аспекте замены
There is one more question in
реальных
the chat
отношений.
about pornography addiction, in the context of replacing actual relationships with porn.
Oh, yes. What's the question?
Как такового вопроса
It's not really a question, it's rather like a
Марина
statement in the
интересно
chat.
просто в целом о
So
порнозависимости или что это
maybe, maybe it's a question of what,
интерес тут.
like, if you could elaborate on porn addiction, how you see this kind of addiction, and maybe how to work with it if it comes up in therapy.
Okay, I would say, and I'm glad, thank you for asking that question, because it brings up a general issue of what is pathology. And porn addiction is one of those topics that there's a lot of dispute about it. I first of all think that porn addiction, does the person feel that they are addicted, or does the person's partner, husband or wife, or boyfriend or girlfriend think that it's a problem? They're different. And so I would say, if somebody has an addiction to porn such that they are not interested in having sex with their partner, but they want to keep the relationship, that's an important question. Again, you're coming up with what do you do where the two people disagree on what's going on in the relationship, and that's something that a couple can deal with. But if somebody, I would want to know also, some people use porn in a very productive way. And I would be careful about calling it an addiction. And I think that captures an important issue when you're doing psychotherapy and somebody says, "I am doing this thing that's problematic." I want to know from the person why it's problematic for them. And if a person said to me, "I have a porn addiction and I really think it's taking up all my sexual time and energy, and I really want to be involved with someone else," that's one thing. But if a person says, I like to watch, I really like watching pornography. Other people call it an addiction, but I don't. And some people will say, "I learned things from pornography that helped me in my sexual relationship with my partner." And so I feel like it captures that important question at the very beginning of the treatment. What do you want? What does the patient want help with? And why do they think it's problematic for them? Did that answer your question?
Марина тут добавила интересный вопрос.
Marina, the author of the question, added something to the original question. She said that she was curious about people sometimes replacing real relationship with watching porn.
They do. They do. However, that's the big question. How much is that the case? The amount of people who watch pornography is enormous. A lot of people are judgmental about it, but also use pornography. And I would say it's an important question. When is it problematic? That's still the question. And how much is it something determined by cultural expectations versus the person's internal feeling? If the person is saying, you know, it's getting in my way. Of course, you can then do an inquiry into how is it getting in the way? Why does the person rely on porn because they're scared in some way of having an actual sexual relationship with another person? There are many other possibilities in why somebody is turning to porn more than to other people. But I would be very careful. I think that's one of the places where the analyst has to be careful not to assume that just because the person says this is an addiction, that it's necessarily problematic or pathological.
Спасибо. Так, много интересных вопросов. Сейчас
Lots of great questions. Let me look through the chat.
Так, несколько есть вопросов похожих.
Do you all see when someone raises her hand?
Да, но я
Is
думаю,
that-
что мы сначала...
Yeah, but I suggest
вопросы в чат.
us taking the questions in
Ольга,
chat
можете
because there are
тоже
lots of them.
писать.
I see. Okay.
Actually, Olga, if you could also type your question on the
Чате
chat, we would be most grateful.
Так, вопрос от Марии. Вопрос
Question from Maria.
Марков. Когда вы говорите о сексуальных практиках,
When you talk about
используете ли
sexual practices,
вы в их концептуализации такое
do
понятие, как
you
перверсия?
ever use
Или вы считаете, что это одна из форм сопротивления
perversion as a
аналитики?
term? Or do you
И
think that
похож
it's
ли
also
вопрос
one of the forms of counter-resistance when we use the term perversion? And a similar question
можем ли мы сказать, что
asked by Hasmik Rutunan. So can we say that sexual perversions is an outdated term? Thank you.
Thank you for those questions. Again, I could give an hour lecture on this, and I have actually in the past. I want to say a little bit about perversion. I almost never use it anymore. And I think if you look at the history of perversion, I think it comes from when you say perversion, it's saying that you're doing sex in the wrong way. Freud actually had a very unusual, to me now, definition of perversion. He said that perversion is a sexual activity that does not lead to regular penis vagina intercourse. So Freud said, if you have oral sex, but it leads to penis vagina intercourse, it's not a perversion. But if you have oral sex that leads to orgasm without intercourse, it's a perversion. And I think that the origin of the word perversion is connected to religion. There is the idea, which I think a lot of psychoanalysts and cultures subscribe to without even being consciously aware that they're doing so, that a lot of the things that in Judeo-Christian or other religious traditions are considered sin are then redefined as perversions. So I would be very careful about using it. I think there are times that it hides an unconscious judgment or an unconscious sense of religious morality.
Спасибо. Так. Дальше вопрос от Юлии Чубаковой.
Another question from Yulia.
Узнать от вас больше, как вы в вашем опыте работы интегрируете сексуальную терапию и
In
психоанализ.
your work, how do you integrate sex therapy and psychoanalysis? So, do you use any particular techniques from other modalities of treatment? Thank you.
Yes, absolutely. I mean, it happens that I've sort of, again, educated myself. I never had a formal training in sex therapy, but I knew Helen Singer Kaplan and certain other sex therapists. And so I've learned from them I sometimes, for example, if a man says that he has premature ejaculation, there are certain behavioral techniques which I'm aware of, and I tell them about them. I explain it to them. Sometimes I even recommend that they read about them and that they try them, and then I have them come and tell me the results. I think it's very important when you use something that's just a behavioral sex therapy technique, which sometimes are very effective, that you also explore the meaning to the patient of you're recommending this, and then sometimes they will bring up other anxieties that were covered over in the initial symptom. So you want to pay attention to both behavioral approaches and the psychoanalytic understanding approach.
Спасибо. Следующий вопрос от Ольги.
Thank you. Another question from Olga. I can see that Stasia has her hand raised. Please write your questions in the chat. I think it will make it more efficient because we have lots of attendance. A question from Olga. What if a queer client wants to explore the origins of their sexuality? What's the best way to do so? For example, can we use psychoanalytic hypothesis about unconscious identification with one of the parents? Can we use Oedipal complex or any of those concepts?
We can, but I would say I think none of us knows why anyone is heterosexual or homosexual. We don't know. So we've come up with many hypotheses. And so I feel like I would want to know first why does the person want to know that? I mean, have you ever had, I think we all know that how many times do heterosexual people say, why am I heterosexual? In fact, I would say this is an interesting thing that happened in the 1970s when I was in graduate school. There were people who came to the university mental health service, men who said it was becoming fashionable for everybody to say they had had homosexual experiences, even if they identified as primarily straight. And so people would come in and say, why don't I feel attracted to other men? Why can't I do this thing? Why do I have to be so conservative? So I feel like it is important to realize the pressure that the culture puts on you to explain things. But for all we know, we don't know. It just seems no matter what, about 10% of the population it has same-sex attractions. About 5% have only same-sex attractions, and about 5% have same-sex attractions with some mixture of heterosexual attractions. And why that is, I don't think we know. So I guess you have to ask yourself, what is the purpose of doing that kind of exploration? You can come up, there are many, many hypotheses. Freud came up with some, but I would say a way to also think about it is say, what is your aim in, what's the aim in asking that question?
Спасибо. Еще вопрос от Юлии Чебаковой.
One more question from Julia. How do you see non-binary gender identity? Is it a real phenomenon, or is it just a kind of a rejection of the concept of gender?
Well, thank you for that question, because I would say that if psychoanalysis really wants to understand that question, there need to be non-binary psychoanalysts and transgender psychoanalysts. I feel like I can answer this question, but I would rather hear from a non-binary person their answer to it. And I would say I've worked with people, we're all to some degree non-binary. I know many of us don't like to think about it, but if we really think about it, there are aspects of all of us. We all have our gender identity is very complicated. So I think, first of all, I haven't said much about intersex. There are some people who have genitalia that are ambiguous, or they have aspects of both primary sexual characteristics, or they have a mismatch of their genetics and their bodily manifestation because of for instance, there's so many syndromes like this, but there are adrenal hyperplasia. If one of the hormones is dysregulated, that even though you have the genetics of one sex, you may look like you have the appearance of another sex. So I would say there definitely is different kinds of gender nonconforming. I mean, those people, you could say everyone who has them who is concerned about it should have a medical workup to understand what is going on with their hormones. Sometimes there's a dysfunction that they need to know about that creates certain problematic things. But on the other hand, I feel like people often say now there are many more transgender people and there are many more gender nonconforming people than there used to be. And how much is that the culture? And I would say you have to look at each person. But on the other hand, you could say it's not that the culture is making people be this way, it's that the culture now has allowed people to express something that they used to keep hidden. And I would say this happened to me with one of my colleagues at a cocktail party. One of my colleagues came up to me and said, "I just want you to know, if I were 20 years old today, I would be transgender. I still am, but I never went and did anything about it, but I've hidden it my whole life." So I feel like you need to be very sensitive to the questions about the cultural pressure and the genuine sense of identity of the person.
Спасибо большое тут. Коллега пишет, какой вы улыбчивый и симпатичный, очень приятно на вас смотреть, Юлия Шапошникова.
One of the colleagues wrote, I love the way you smile.
Thank you.
Thank you very much.
Дальше к вопросам. Более сложный вопрос. Как сохранить этическую, аналитическую позицию в
one more
работе с человеком,
question.
чьи сексуальные предпочтения
What if the person who comes to you admits pedophilic desires? How to keep analytic neutrality?
Did you say how to keep from analytic neutrality or to keep analytic
No, how to
neutrality?
maintain analytic neutrality?
It's very hard. I would say that's one of the most difficult areas of sex, because my own stand, and this is my stance, is almost anything anyone wants to do sexually, if they can find another person who wants to do it with them and it doesn't cause harm to either person and it's totally consensual, is okay with me. But pedophilia, unfortunately, is not. It's a child can't give consent. And so I would say that it's a very big problem. And let me just tell you an anecdote. A colleague of mine heard my lecture where I said, if you really want to understand any kind of sexuality, you need to talk to the people who practice that sexuality and hear from them what they think. So she had a patient who was accused, he said unjustly, of having sexually molested his granddaughter. And the family was saying he was a pedophile. So she called up the man who is the head of there is a pedophilic organization in the United States. And she called him up and she went and interviewed him. And he explained to her, I thought, with a great deal of expertise, how objectively she could determine whether her patient had in fact been pedophilic or not. And I would say it was a revelation to me. I wouldn't have known those things. And I think that's an example. If you have that, you really have to educate yourself. You really should go on the websites, hear what pedophiles say. Some pedophile, the question earlier about masturbation, some people say the solution for pedophiles is, unfortunately, they can't do what they want without committing a crime. So in fact, if they watch pornography, it is less likely to cause damage to another human being. On the other hand, at least in the United States, it's completely illegal to watch child pornography. And so it's a very tough question. And I feel like we should be, if this whole group of 600 people wanted to know more about pedophilia, you should invite someone who is a pedophile and who's really thoughtful about it to talk about it. When I had that study group, we never brought in a pedophile, but maybe it would have been helpful to have done so, just to get an understanding from within the person who is experiencing it. I mean, I just want to say one other thing. I don't know if this is true in any of your countries, but in the United States now, clinicians are required by law to report anyone who is sexually or physically abusing a child. And so in a certain way, it puts when you ask the question about neutrality, part of neutrality, you have to kind of inform the person that that is the law. And it makes it very hard to just want to listen to the person in an open-ended way.
There is a comment from Yulia in the chat. Maybe not all desires have to be fulfilled in reality. They are desires after all.
That's true. That's one approach. And, there are people who that's their solution to sexualities that are problematic. And, one of the treatments of people who were convicted pedophiles was to give them hormones that basically canceled out their sexual desire. It's a terrible thing, but it worked, unfortunately. So not all things are solvable. I just want to mention, by the way, there are many aspects of sexuality that I've thought about, I don't have a good solution. And I think when you go to other cultures, you really learn about this. I taught in Japan in 2009, and I gave a lecture about sexuality. And it turned out several people in the audience said, in Japan, one of their greatest sexual problems and one of the most frequent things people are sent to treatment for, they're not actually necessarily going to treatment voluntarily, is that men on their trains often grab women's bodies. And it's so much a culturally common thing to happen. So the Japanese government ended up creating one door for men and one door for women, so that men and women the men wouldn't have a chance to do this so much. And they still did molestation. So now they have this is in 2009. I don't know where it stands today, but they then developed separate cars on the trains for men and for women. But the culture doesn't tell men this is a problem. The women say it's a problem, and so for the psychoanalysts, it puts them in a difficult situation between the law, the culture, and their own thinking about the sexual issues.
Спасибо большое. Так, коллеги,
Thank you very much.
не волнуйтесь, у нас еще полчаса есть, так что...
We have 30 more minutes. I see that people panic in the chat, but we will try to take as many questions as we can. A question from Yulia Lokova. She's asking about the narrative approach by White, David Epstein. The narrative approach says a lot about stigmas and about the domination of norms in the society. Do you agree that a big portion of the suffering of LGBTQ plus patients is of social nature, not of intrapsychic nature? And if so, how does it inform your analytic technique? Thank you very much.
Okay. Did I understand the beginning was about, you said something about Epstein? Is it?
No, it was about the narrative approach by Michael White and David Epstein.
Oh.
So the narrative approach says that basically these are all constructs and the pressure we get is from the society, not from our intrapsychic forces.
I am wary of oversimplifying anything. And I feel like what you just said, it's definitely a factor, the societal pressure, but it's not the only factor. And I would be careful, anyone who says that there's one way it goes and that's it. I don't want to accept that. I want to know from a person how they've experienced societal pressure. I want to know from them how they experience family pressure. I also want to know from the person how they just have experience of their own sexuality. And sometimes it's a combination of all three, but I don't want to oversimplify it. And I would say that's true not just for homosexuality and heterosexuality, but for any kind of sexual desire that there may be cultural pressure about.
Спасибо. Так.
Thank you.
Вопрос. Так, не знаю точно, от кого хотелось бы коснуться темы сексуальности.
It would be interesting to talk about sexuality in working with teenagers.
Yes.
Такой очень общий вопрос.
Was that a question? Am I allowed to answer that? I'm sorry, go ahead.
Yes, please.
I want to say about teenagers, there's so much to say, but I love working with teenagers. I feel like it's so much, you can make such a difference in a person's life. So, sometimes most of the people I work with are not teenagers. Most of them are older, and a lot of times they've had a lot of suffering, sometimes because of ignorance, or sometimes because of something that just never got resolved earlier. So I feel like teenagers are it's thrilling to make a difference in a teenager. And you have to be very careful, because also in some ways, people who are teenagers are much more confused, and it's harder to know how they are coming to their conclusions. And you have to be, I feel, especially careful, but I feel like the earlier somebody can deal with questions, the better. And I would just also mention, since someone raised about gender nonconforming questions, or question of transgender, which is such an explosive topic now, at least in the United States. It's almost impossible to talk about with people starting to yell at each other. But I would say, teenagers experiment a lot, and they should experiment a lot. I think it's good for people's mental health and to experiment. And often teenagers do things not because of cultural pressure. They want to do things against cultural pressure, and especially they want to annoy their parents. People like it's part of the thrill of being a teenager to rebel and come up with your own views. And so if an analyst can be sort of with the person on all those aspects without trying to come to any certainty too fast, I feel like that's a very important factor in working with teenagers.
Thank you very much.
Значит, вопрос от Светланы Якофаровой.
Svetlana Yakofarova is asking, thank you for the lecture. She says, it was very interesting to hear what you think about asexuality. Should that something to treat, especially, is it a sexual preference, or is it just avoidance, repression of the whole topic in general?
These are wonderful questions, and they really capture the fact that there is no simple answer to that question you just gave. And I would recommend, if you are really interested in asexuality, there are many asexuality websites. And the people in those websites discuss these questions among themselves. Some people say, I don't feel any sexual desire. Some people say, I feel it, but I don't want to act on it. And some people have another formulation. There isn't one simple formulation about asexuality. Now, if somebody says to me, I feel no sexual desire, and I want help to be able to feel sexual desire, that would be an important question. And I feel like the case of Anna O was a very good example. Breuer thought she was asexual. He said, I worked with her for 2 years, and she never once expressed any sexual fantasy or any sexual desire. So he thought, isn't that interesting? Freud said to him, oh, you just missed it. And in a way, I think he did, but I think what looked like asexuality wasn't asexuality. And you read that in Sisyphus Arbeit, you realize she was not asexual, but she may have actually behaviorally been asexual. She may have behaviorally not ever had sex with another person, although I think we don't know that. But I feel like when you ask a question like that, you got to talk to the people who are calling themselves asexual and see all the different formulations that they come up with.
Thank you. Just a moment.
Вопрос от Лены Райх.
Lena Reich is asking, if a client is very worried by not experiencing vaginal orgasm, and she believes it doesn't exist at all, and when I give her scientific literature, it doesn't convince her, she cites what her friends say and people on the internet say, that it does exist. So maybe if you could orient me in how should one go about it, a couple of words. She just doesn't accept the fact that it doesn't exist.
That a vaginal orgasm doesn't exist?
Yeah.
Does she say that no orgasm exists, or just that they only are clitoral? I don't understand what she means by doesn't exist.
Вагинально. Вот, то есть, сейчас я попробую
I will try to reformulate in the way I understood the question. So the client is worried that by not having that vaginal orgasm, and no matter how hard I explain to her that vaginal orgasm does not exist in nature, she's not convinced by any of it. She believes that other women have it, that her female friends do have it, while she doesn't. So she's not convinced by any facts, and that worries her.
Well, I'm a little worried. I don't know that I agree with you that it's a fact that vaginal orgasms don't exist. I feel like orgasms exist. Some people feel them in their vagina. Some people feel them some people have a whole body orgasm, and not everybody does that, but some people do. And there are men who experience their orgasms very differently. Some men experience their orgasms primarily in their penis. Some people feel it in their testicles. Some people feel it in their prostate. It's really impossible to decide how much that's just something subjective, but I feel whatever somebody feels is what they feel. And so I guess I would wonder, I mean, in a certain way, does it matter if you have an orgasm? You should have the orgasm the way that feels best to you. And if you have an orgasm, whether you feel it primarily in your vagina or not in your vagina, how much is that a problem for the person? I guess that would be my question, but maybe there are other, this is a good example where if we had a smaller group, maybe we could have the women talk about that question, because I know that it's in the history of psychoanalysis. When Freud said that, people believed him. And what Freud based it on, I'm not sure, but they believed him enough that Marie Bonaparte went and had surgery done to move her clitoris so that it would have more direct stimulation during intercourse. It didn't work, but that's how far she went with believing Freud. So I've read a number of papers over the years about this question. And some women say, oh, I have both kinds of orgasms and they're different. And fine, that's great for, some of it. Does that mean that's true for all women? I feel like we don't really know the answers to these things. And it is an interesting thing, though, that people say, well, I hear about it from my friends, so why don't I have the experience that my friend has? Well, I feel like we all have different experiences. On the other hand, I'm just go there. I can't remember her name. Betty Dodson. I don't know if any of you have heard of Betty Dodson. Betty Dodson was a woman who felt that women are trained not to really pay attention to their anatomy. And so she formed these groups, which went on for decades in the United States, where women would sit in a circle. They would all they could each look at each other's genitals. They could see how different people's genitals are. And then they would masturbate together in the group and talk about with each other how they masturbate, how they felt things. So that women, I feel like that was, if you want data, if this woman wants data, it is possible to have it. It's not something that I feel, at least I'm not aware of. There's not a whole lot of scientific research. People don't, at least in the United States, the government doesn't give grants for people to study female orgasm. And so it's it's something that people have to explore. And I, as a therapist, would much rather have the person do exploration than tell her what is correct or incorrect.
Спасибо. Так, вопрос от Натальи.
Natalia Simshina is asking, what's happening now in counter-resistance, in sexual counter-resistance? What are the trends? Is there more counter-resistance or less? In conferences, is it still that research about sexuality doesn't get that much space and attention? What does it say about our social trends? Where are we moving towards? A greater sexual liberation, we as a society, or less of it?
Well, that's a great question, except I have trouble with the word we, because I can't speak for what's happening in every part of the world. But I can say in the United States, that's definitely the case. There is definitely a pressure against, the government is very restrictive in its view about what sexuality should be. I think, gay rights was something that had a tremendous trajectory, got better and better and better. I don't know that we thought it was going to ever turn around and become worse, but it is. It's becoming worse very fast. And for people who are transgender and gender nonconforming, it's very bad in the United States right now. And people are scared, and some people either move from one state to another, or they move out of the country and go to Canada where things are better. But I feel like you have to, it's different in every part of the world. There's also, at the same time that the official social stance is very much more anti-sexual than it used to be, there is this enormous activity on the internet of speaking openly about sex. And the two things are going on simultaneously. And, periodically, every so often, somebody who's very judgmental about sex in the public stance, very often government officials are then discovered to have secret lives on the internet. And so it's really churning very much. So that's the short answer. The long answer would require talking about Hungary and each of you talking about your country of origin and how things go and how they've changed over time.
Спасибо. Так, вопрос
Thank
Ольги
you.
Павловой.
Olga Pavlova is asking, what are the obstacles? What in the analyst's counter-resistance stands in the way of exploring? Give me a second. I need to reformulate the question. A moment.
В общем, влияет ли как-то и мешает ли исследованию?
Can it be an obstacle to explore? I'm sorry, let me go again. I will just read it out loud, what Olga writes. What are the obstacles and what in the countertransference of the analyst stands in the way of exploring patient sexuality and talking about sexual context? What in the analyst's person maybe, or what in the analyst is the problem? What generates counter-resistance around sexuality in a given analyst or therapist?
Okay, that's a good question, but I feel like it's the task of every analyst to answer that question for themselves. First of all, the analyst has to be aware of when they feel that resistance, and then they have to discover, why is that going on? I mean, as I said, before, I had that supervisor. She felt the disgust reaction. She couldn't stand it. She just couldn't hear. I mean, it was, and she didn't want. She said, "I don't need to listen." She didn't say, "I don't need to." She said, "I won't listen to it." So I feel like all of us have discussed reactions that are different than other people. I mean, when I was, when you have to look at, is it my personal psychodynamics? When I was in training, during my internship, one of my colleagues said, "Oh, I'm finishing my internship. I want to send you a patient. He's the most boring patient I've ever worked with in my life." And he sent me this patient. The patient was fantastically good looking, and he wasn't boring, but to me, but the analyst, I think, was made so anxious about how good looking this man was, and he was, manifestly, the analyst was heterosexual. He couldn't bear it. I think he couldn't bear those feelings. So you have to wonder, is this a personal reaction with feelings that I have difficulty with? And then, there are things like there are just the knowledge is so important. I have a paper called Psychoanalysis and Sexual Issues that has a case that I worked with of someone, I talked about heterosexual voyeurs. And this man came to see me, and I'm embarrassed to say this, but I'm so stupid. I said, "Well, if you like looking at women, why don't you go to one of the strip clubs and you can watch women all you want in naked, dancing." And it turns out, which I didn't know then, was that most heterosexual voyeurs, it's not exciting just to see women. The exciting thing is to see women against their will and without their knowing it. It's a combination of sexuality and power, which I didn't get. And so I learned that from him. I think one thing you can do is try to learn from your patient, try to explore your own psychodynamics. Sometimes an analyst has a traumatic experience from their childhood that they then bring into the treatment. That there's so many possibilities for that, but each person is responsible for learning that. If you have an experience of even potential sexual abuse when you were a child, and then a patient comes in who is a victim of sexual abuse, or maybe even, a pedophile, you may not be able to work with that person. Or you may not be able to unless you really develop your own self-analysis. And can I just add one little thing there? I personally think that the best way to work out your counter resistance is with a group. In my experience, although I've had very wonderful experiences in individual psychoanalysis, when these issues come up, I feel like hearing from several people gives you it's much less anxiety provoking, I think, and it also gives you a much more balanced view. Um, and I would say a lot of these questions, I think, would be answered very well with several people bringing their points of view together and really dialoguing about them.
Спасибо за ответы. Еще вопрос.
Thank you for responding.
На эту же тему. Вот
a question in the similar direction. Salim asking about the analyst's counter-resistance. Can it have to do with how intimate the topic itself is, and with the therapist's fear of being intrusive or prying in that sense? Or maybe, the therapist is afraid of intruding. Or you mean when the patient initiates or brings up a topic and then the patient ignores it, or not the patient, the analyst ignores it or just changes the subject. So what is more problematic?
Yes. Well, I gave that example of the woman whose gay patient said he did all his favorite sexual things and she just didn't want to talk about it. And I mean, that is a big issue. And there, again, with that, there is also a balance that you have to sort of follow the interaction between you and your patient. Sometimes, you know, you could be intrusive, but sometimes you're being avoidant. And how far are you going in either direction is very hard to determine in the moment. And sometimes I ask patients, if I just happened to me recently, a patient I think wanted to discuss very much the intimate details of his sexuality. And he said to me, "Is it okay if I talk about this?" He said it outright. And I said, "Absolutely. I want to hear as much as you feel comfortable telling me." I feel like either both patient and analyst, the resistances can swing back and forth between them, and probably do. It's not that it's just one. It's not usually just the patient or just the analyst. Um, so let's see.
Так. Спасибо большое. Ну, наверное,
Thank
еще
you.
вопрос
And
один.
maybe one
А потом
more
я немножко
question.
расскажу про нашу программу, которая у нас
Then
скоро
I'll
начнется.
talk about our
Вопрос от Ольги.
program.
Спасибо за лекцию.
Olga
Как
is
будет
asking
свежий
and saying,
вопрос.
thank you for the lecture. It's like
Подскажите, как влияет степень открытости своей
pressure.
идентичности
So how
терапевта на терапевтический процесс?
one's openness, I mean, in the analyst about their own sexual identity and gender identity, how does it affect the analytical process? Does the analyst, should the analyst necessarily self-disclose?
That's another very good question. Thank you for that, Olga. I would say that that's another one of those things that I feel like you need to find a balance with that. If there is no, all these questions they sound like they have a simple answer, like should the analyst self-disclose? I would say, you know, when I started out in psychoanalysis, there was a rule that analysts didn't disclose anything about themselves. And I know that has changed a lot over time, but that was my first training. Just you don't say anything. You can say anything you want about your immediate reaction to the person in the moment, but don't tell them anything about your personal life. And sometimes uh, that's a problem, but it's also possible you don't want to overload your patient with things that they don't want to hear. If you feel like I'm telling the patient this for my needs rather than the patient's needs, I think you sometimes have to catch yourself. And sometimes patients will tell you that. They may tell you directly, they may not tell you directly, they may tell you with a dream. But you know, can I just say, I'll give one example. I got married, I don't know, many years ago, I don't know. And I started wearing a ring. And I came into session, you know, most people who saw the ring said, "Congratulations." I had one patient who was so traumatized by my getting married. He had a whole history of his parents divorcing, remarrying. I mean, he had had so many fathers. It was really traumatic for him. And so for him to notice that I was having a change in my personal life was so disturbing. I didn't do it on purpose, but you know, I had the ring on. It's a good example though to me of how you can't know how your personal information is going to affect your patient. And if you're going to do self-revelation, you have to be I think you have to be cautious, and I think you have to also pay attention to what happens afterwards. That's what I would say.
Спасибо большое, Марк.
Thank you, Mark. And now I will say a couple of words about the program that we have set up. It will be launched very soon. If you don't want, you don't have to stay for the announcement, but it will be very short.
I just want to hear it. I'm
starting,
Okay. Да, что с этой лекции началась наша, собственно,
starting
большая программа про гендер и
this
сексуальность.
lecture, we have launched the big program on gender and sexuality, the erotic in psychoanalysis, with 14 lectures, all very different. There are people from the States, from Europe, from the United Kingdom, one Argentinian, the former president of the IPA, Virginia Ungar, and there will be a lot of eminent specialists in their respective fields who have made great contributions into this topic, this field, with very different theories, approaches, psychoanalytic schools that they represent. So we've had Dr. Bleshner with us, who is an interpersonal analyst, and we'll have other interpersonal specialists and relative psychoanalysis will be represented, relational, and contemporary Freudian, and many other modalities and attitudes and stances. So please join our program, sign up, and we'll be very happy to welcome you there on the program.
Okay. Can I just say thank you all for being a wonderful audience and for those very stimulating questions, and this program that you have outlined sounds just terrific. Thank you for letting me be part of it.
Thank you very much. And with that, we will finish for today.
Goodbye.
I will stay for a moment. Goodbye.